I think you're referring to pulse field ablation? Yeah.
So you were like,
That's
is
right.
there something for
Yeah, so basically that is the benefit of this technology, the energy used to ablate the cardiac tissue. It's a local field, first of all, it's not wide. It's delivered from the catheter. And that local field is basically at a low enough energy where it only ablates myocardium and spares nerves and spares other collateral damage as well.
the nerves that nothing?
It doesn't affect nerves. So you bring up a point that there's a point that whether you lose something by doing pulse field ablation, whereas ganglionic ablation, you don't get that benefit. So you do not get that benefit. And there is a PFA catheter that does both for presumably that benefit as well. So, yes.
Is FDA approved pulse field in the United States?
No, so it should be it should be approved the first quarter, second quarter of 2024.
Yes? Question back.
VT, yeah. So, yep. So, great question. I think it can help, but I think the field is really, when you have a scar tissue, it's moving away from figuring out where the exact mechanism of VT is coming from, and it's moving more towards an anatomic ablation where you have an area of scar with potential problematic tissue all over the place, and we're going to move to large, potentially PFA again, where we can go in and do a quick ablation and homogenize the scar. AI, I think, will play a role if you're trying to figure out a individual mechanism of an individual VT. But I think in terms of saving time on an ablation, I'm not sure at this stage.
So one question is that, Sean, some of the slides for your preserved ejection fraction, 40%, 50%, what it is? They're asking that what exactly we would define the preserved EF, is 40 or 50? 50.
It's now 50%. So
How
about that? That's better. Yeah, there was a consensus document, a Pan Society document that was published in 2021, into 2021, beginning of 2022, that redefined what heart failure is. I showed you, clinical symptoms and objective evidence of congestion, but they codified the different cut points. So for those patients who have an ejection fraction less than 40%, we now refer to that as heart failure reduced ejection fraction. Between 40 and 50%, mildly reduced ejection fraction. And then between over 50% would be heart failure preserved ejection fraction. And we can quibble quite a bit about whether or not ejection fraction is the right thing to use to guide our therapies and whether or not we should be treating specific pathophysiologic mechanisms and phenotypes. But nonetheless, right now, our thinking is still codified around the ejection fraction.
Yeah, so in our international trials also, when we call normal EF is about 50%. So I think 50 is consistent. So actually, a lot of elective EP questions. The one is ablation of AFib causing scar tissue to stir up more AFib.
Yeah, so, there's several studies that show beyond pulmonary vein isolation, whether there's a really benefit of ablating in scar tissue. Most of the results have been negative, still people do it, but DCAF2 study specifically, I think. So when we do pulmonary vein isolation, AFib ablation, the gold standard is just doing pulmonary vein isolation. But in patients who've had persistent AFib, a lot of people feel that that's just not enough because there's other substrate, potential rotors, areas of scar, and people target those. But overall, the body of evidence has come out not particularly in favor of doing that. So meaning that there are some studies that say it's positive, some studies that say it's negative. The big randomized studies pretty much say it's negative. So people still do it though.
But I think the question, it's an interesting one, but I think the question might be that over time, there's some scarring that forms after the ablation,
yeah.
like you
I see.
said, pulmonary vein thrombose, stenosis, all of that. will that also beget more AFib?
Yeah, I don't know the answer to that, but usually the scars we create are homogeneous and designed to specifically limit electrical signals from going across. So in terms of, there is what's called a stiff LA syndrome, which happens after extensive ablation. The atrium becomes stiff and it does affect function after an ablation, but whether it's arrhythmogenic itself, I don't have any data to say yes or no.
And then what is the success rate of ablation in reserved EF? Any difference in, the question is, what is success rate of initial as well as re-ablation in patient with heart failure with reserved EF?
Yeah, so there's no randomized studies to say that. I show you the randomized study. There's sub-studies of two particular randomized studies, East AFNet 4 and Cabana, which are both included patients with heart failure, about 30, 28%, 40%, somewhere in that range of heart failure patients. The heart failure patients in those were predominantly HFpEF patients. And when you look at the primary endpoints in the sub-study, they had equal benefit as HFrEF patients. But again, they weren't specifically designed to look at that population.
Who do you not ablate after that talk you just gave us?
Yeah.
So we have a large group. I tend to be one of the conservative ones in terms of indications for AFib ablation. But I got to tell you, over the last couple of years, as the data is coming out, it's hard for me to sit across from a patient and tell them that you're doing okay, you're in AFib, you don't have any symptoms, when I see that data about cerebral perfusion, dementia. So I become more aggressive. Is there a person I absolutely want to ablate? I mean, I think you have to take it case by case basis. I don't use age as a cutoff.
Yeah, well, when the EF is low, though, one could make a very strong argument to do it. I mean, there it's not, I don't think, as much a matter of personal preference. I would actually, barring any sort of safety issue or contraindication in a particular patient, push them towards ablation if they had heart failure with reduced ejection fraction. But do you think that's a general sentiment in the heart failure community?
Oh, that's a loaded question. No, I don't think it's a general sentiment. I'm sure Srini would agree. It's one that I have, which is I think that the data are very compelling. And I often refer my patients with paroxysmal atrial fibrillation in the context of reduced ejection fraction to AFib ablation. The problem I have is that a lot of them, when they're feeling well, don't want to entertain the idea of ablation. It's really a symptom-driven intervention. So if they're in AFib and they're very symptomatic, I can get them to ablation, but asymptomatic ones, I have a hard time.
By the way, I saw one of your patients from long back. He's in AFib for a long time. Yeah, I'm sending it back to you. He wants to see you again. He doesn't.
I think another thing that's really important that often people have like a misconception is that post-ablation, you still need the anticoagulation. And I think that's the part that many feel like, well, now I'm in sinus rhythm, I don't really need the anticoagulation. And I think that's a really big misconception that we're seeing now. And I think there's a huge number of patients who have atrial fibrillation who were not anticoagulating that we need to kind of get our arms around. Would you agree to that?
Yeah.
Means everybody still should be on?
Yeah, so, I mean,
Well,
often
I'm the
people.
first one to stop it after a few months.
Yeah.
That looks good.
I think low-risk patients, I think we generally agree to discontinue. But I think you have to, these high-risk patients, high CHA2DS2-VASc score, I mean, it's really, you're dealing with a larger process than just AFib alone. Atrial myopathy, you see these patients in normal rhythm, large atria, but they're no contractile function, smoke. So I really do not use ablation to stop.
Left atrial appendage closure if you really want
Yeah.
to stop the anticoagulation. Another, you can send him.
Yeah. Okay, so now actually, Deepak, question for you. What percentage of patients develop AFib in the reduced IT trial? Reduce it.
Yeah, it's a good question. You know, the rates overall were pretty low in absolute excess of 1% over 5 years in terms of developing atrial fibrillation. So, you know, each year it's in excess of about 0.2% that there was. But, you know, it was a statistically significant finding. And I think it was a real finding too, because we also looked at patients with a history of prior AF, and that's where the AF episodes in the trial largely clustered. So it did make it seem more plausible that the excess risk was largely confined to the subgroup where you would expect it to, that is, people with a prior history of atrial fibrillation. But I'll point out that even in the subgroup of patients that developed atrial fibrillation, there was no excess of stroke, which is obviously what we worry about. In fact, as in all the other subgroups, stroke was in favor of the drug. That is, there was less stroke in that subgroup, and in the overall trial, there was a significant reduction, a 28% reduction in stroke. So I'll point out as well, in the trial, we didn't actually give any guidance to the investigators to do anything with respect to this study drug. That is, we didn't say, oh, if they develop AFib, stop it. So whatever was experienced in the trial in terms of event rates was with the patients, typically just continuing the drug. So I think in real life, the ramification of that is if somebody has really poorly controlled AFib, I wouldn't start the drug. But if somebody is well controlled in terms of their AFib, beta blocked, rates fine, then I don't think there's an issue with starting it. But you should still be cognizant of the fact that there's that small excess risk.
Okay, and based on the reduced IT trial, do we need to test any fatty acid panel or omega panels before starting IP and EPA?
No, I wouldn't recommend it. I mean, those tests are out there. There are some folks in preventive cardiology clinics that do measure baseline EPA levels. There's some that measure follow-up levels, just look for adherence. But, none of that is in the labeling of the drug. None of that's in the guidelines. So I don't personally do it, but there are some relatively few folks that do that. Within the trial, we looked at patients across baseline EPA levels, which were pretty low in the largely Western population studied in the trial. And there was benefit irrespective of what the baseline EPA levels were. So sometimes people say, oh, well, what if the patient just eats a lot of fish? Isn't that good enough? Even then, they don't get to the levels that the drug can provide at the dose that was given in the trial. And there was benefit even, say, in the highest tertile of baseline EPA. So if one wants to eat a diet that's high in EPA, that's probably good for cardiovascular health, but doesn't really obviate the need for this type of therapy in the right patient.
Okay. So which should be the patient beyond going with give somebody fenofibrate, somebody we give all the statins, which patient you will start?
Sure. So I in the current era really wouldn't give fenofibrate in general. I think the trials pretty clearly show that there's no benefit, most recently the prominent trial. So the only time I ever recommend fibrates is in the hope that fibrates prevent pancreatitis in people with triglycerides greater than 500. So, that's the one place I think there's use for fibrates, although one can also use high doses of omega-3s. One can use icosapentaethyl at a dose of 4 grams per day. So I think any of those are potential options. Myself, I'd favor icosapentaethyl because there's cardiovascular risk reduction data, not in those with triglycerides above 500, but in the range we studied in the trial, which was 150 to 500, but I'm willing to extrapolate. So my own algorithm typically these days is icosapentaethyl, 2 grams twice a day if the triglycerides are above 500. And then if it's still elevated and they're adherent to that, then add the fibrate to that. But for cardiovascular risk reduction, so triglycerides are less than 500, but you're worried about cardiovascular risk, there I would go with icosapentaethyl as a first-line therapy. I wouldn't use fibrates, I wouldn't use niacin. But in terms of the approach to that patient, the first line should be dietary counseling and lifestyle modification. Some people's triglycerides are elevated just because, they're drinking a lot of alcohol, or they're eating a really unhealthy diet, or they're very overweight, or they have poorly controlled diabetes, or they have undiagnosed thyroid disease. But, once you've done sort of the basic internal medicine screen and those things aren't present, the lifestyle modification has occurred to the best degree it can. Statins would also be the first line therapy. And then if the triglycerides are still in that range of elevation, that's a reduce-it-like patient where one should consider icosapentaethyl, especially if they're at high cardiovascular risk, certainly in those that are secondary prevention or consistent with the label, high-risk primary prevention, namely diabetes and additional cardiovascular risk factors.
Beautiful. Now, actually, Srini, the question back to you. You did mention, but people want to know, which patient you can stop anticoagulation after successful ablation, and does it require ILR?
Yeah. So I don't typically use ILRs,
Okay.
Make that decision. I don't typically use ILRs to make that decision, but I guess the way I approach it clinically, I don't use gender as a risk factor. But one or two CHADS VASC, otherwise, I'm okay with stopping anticoagulation. But once you start getting into 3, 4, 5, even with the ILR, I'm hesitant to stop anticoagulation because there's data that shows there temporarily episodes of AFib may be unrelated to embolic events.
But with low CHADS VASC, post-ablation, do you not still continue anticoagulation for some period
Yes.
afterwards? I mean, that,
Yes, you have to do at least minimum of 2 months. And the reason for that is when you're ablating in the left atrium, you can get thrombus from the areas you ablate and risk for embolic events. So that's the reason for the 2 to 3 months of anticoagulation afterwards. But after that, if everything looks good, we stop it in the low-risk patients.
Now,
I think obese patients are writers, right? Would you stop with obese patients?
Well, look, I think just going on one thing, obesity, is not, I can't make a decision on that. I think you just have to look at the whole patient. If their only risk factor is obesity, I don't have a problem stopping it. Yeah,
and do you anticoagulate CHAD VASC score 1?
I don't.
No. Okay. So now, other question is still with the triglyceride. Maybe Deepa, you can comment on it. One, do they need to measure any triglyceride-rich lipoprotein or VLDL when you will start the therapy for high triglyceride?
I don't personally do that. There are some folks out there that are big fans of ApoB, feeling that it sort of, amalgamates the risk from both LDL and triglyceride-rich lipoproteins. I don't think that's an error, but I don't do it myself. And, at least the large studies looking at the predictive value of LDL ApoB don't really show that much incremental value. But I do understand, again, some people believe, just based on the science, that ApoB summates the risk across both LDL and triglycerides better than each one. So I just stick with, LDL and triglycerides. I personally like a direct LDL if it's easily available, and triglycerides and HDL and total cholesterol otherwise comes with a typical lipid panel. I, generally speaking, don't go into LDL or HDL subfractions. Again, I know some lipid specialists and preventive cardiologists love all of that, but it's not necessarily putting you down on any evidence-based pathway. Wouldn't change what I would do myself in practice. I mean, in general, I shoot for a very, very low LDL cholesterol to the point where, as long as the patient isn't having side effects. But in at-risk patients, I think that's the way to go, as was discussed this morning by Dr. Fuster and Dr. Mehran and others. And then in patients that also have elevated triglycerides, I, again, treat it the way I mentioned before, with lifestyle modifications, statins, and if that doesn't do the trick, icosapent ethyl. But I don't, in general, look at all the different fancy lipid biomarkers. Again, I think it's fun, but it's not necessarily guiding in a therapeutic pathway.
Okay. Now, Roxanne, a question for you. As you've shown the guidelines now that aspirin is stopped after 3 months, now you continue ticagrelor. Now you stop ticagrelor after 15 months or maybe 30 months based on Pegasus trial. What do you do after that? Go back to aspirin?
No, it's a good question. I think based on the patient's risk, you can go to a clopidogrel monotherapy as well. There's no real data on any of that. And actually, there's really the only evidence we have right now is the aspirin indefinitely, but what's the evidence for it? Against what? I mean, I don't know that we really have up against aspirin alone versus clopidogrel monotherapy. There's one trial that looks like clopidogrel monotherapy is better. But we really need a much larger trial, and we're hoping that we could hopefully design that. So you could do a lot of things. You can go to lower dose ticagrelor, no evidence. It's an idea to do that de-escalation to clopidogrel monotherapy or going back to aspirin monotherapy.
As you have shown on the cardiac point of view, clear, but any signal of the higher cerebral event when aspirin was withdrawn?
We were underpowered for those events. Obviously, there was a numerically, maybe one more stroke or something on that, but that is not at all something to say that we really have any evidence that there was any kind of a ill-toward effect. But obviously, we would have to study this in much larger populations before we could say yay or nay.
Yeah, I think it's really tough to know because there's so many trials and so many comparator arms. It's hard to know exactly. I think, unlike just sort of the algorithms for LDL lowering or perhaps triglyceride lowering, with antithrombotic therapy, you've really got to individualize it a bit based on the data and guidelines as best you can. But, for the clopidogrel monotherapy option, I mean, I've been a believer in that for a while, going back, 25 plus years from the Capri trial, where it actually did beat aspirin for monotherapy. So even though aspirin monotherapy remains the bedrock globally for secondary prevention, one could make an argument that generic clopidogrel is better based on that data set. And more recently, a trial from East Asia, host exam, that took patients off DAPT and then randomized them to clopidogrel aspirin. So, two well-done randomized clinical trials separated by a couple of decades, but basically finding the same thing, the clopidogrel beats aspirin. The DAPT stroke question is a tough one because in Charisma, we actually saw a statistically significant reduction in stroke in the overall trial with clopidogrel plus aspirin versus aspirin alone. In Pegasus, we saw a statistically significant reduction with ticagrelor plus aspirin versus aspirin alone for ischemic stroke and for all-cause stroke for that matter. And in Themis, we also saw a significant reduction in all-cause. Of course, that was ischemic stroke. So, there are a bunch of DAPT trials. And then on top of that, you've got the dual pathway inhibition with Compass, where stroke was also significantly reduced, in that case with aspirin plus low-dose rivaroxaban versus aspirin alone. But the challenge with all of those trials is the comparator is aspirin, unlike in Twilight, where the comparator is ticagrelor monotherapy. So that's why we have a gap in data. So for sure that the monotherapy, I think the one thing I'm certain about is you can do better than aspirin monotherapy. That thing I'm certain about. What that strategy is, whether it's clopidogrel monotherapy, ticagrelor monotherapy, DAPT in some patients, that's open to debate and discussion. But I think the aspirin sort of being the standard of care, even though it's cheap and familiar, that time has really passed. The data show that you can do better than that.
All right, any questions? Yeah.
It's about high triglyceride patient. So I recall a patient who had very high triglyceride and the PCP had put on the full dose of Ashtafa, that is hypo. And also statin, but LDL was okay. She was not obese and she was not drinking alcohol, which could be reason for triglyceride. And she said she has dietitian or nutritionist PCP if she's following that. It was still around 500, the triglyceride. What do you do next?
Yeah, it's a great question. Actually, icosapent isn't the strongest triglyceride-lowering agent. It just reduces triglycerides by about 20%, maybe 25% if you're lucky. So in that sort of patient, I would add a fibrate to get the triglycerides under 500.
Or enroll in Dr. Rosenson's trial.
The new
Oh,
trials.
yeah, actually, that's a better answer than mine.
There's lot.
No, what Dr. Mehran said, in clinical practice, if there was no access to experimental therapies, I would add the patient you mentioned who's already on a statin, hopefully at maximally tolerated dose, already doing everything with diet and weight. Glucose is well controlled if they have diabetes. They're on icosapent. There I would add a fibrate, likely fenofibrate. And that would almost certainly then bring the triglycerides below 500. What Dr. Mehran was saying, as I mentioned in the talk, we're participating in a trial here, the Entrust trial, that's looking at a novel injectable agent called pegozafermin that lowers triglycerides by about 50%. So if the patient has triglycerides between 5,000 and 2,000 and the level is stable, rather 500 and 2,000 and the level is stable, then you could refer them to Dr. Rosenson, or for that matter, Dr. Wakasmalik, and then they can decide whether the patient's in the trial.
GLP-1 can help with triglycerides?
Yeah, diabetic control in general, glycemic control in general can help, weight loss can help, and specifically GLP-1 agonists also do have a modest, very modest effect on lowering triglycerides.
Okay, sorry, question.
Yes, now that you're promoting more privates over pivotal over aspirin, do you ever look into the verified regular patient sure we
So one, I don't think we're promoting, I just want to make sure that you understand that. I think we're just telling you what the clinical data show, and I think Dr. Bhatt really said it nicely. We have now old data from Capri, which showed that clopidogrel beats aspirin, both in bleeding and ischemic complications. And we just have the host exam that also did the same, beats aspirin monotherapy with clopidogrel monotherapy. Clopidogrel beats it. What do I do? There are in complex patients where might be worried about the, no one knows whether or not checking the platelet function tests and certainly changing your strategy does anything to improving outcomes. So that's really important. But nonetheless, I think if I'm worried about the patient and I want them on something and I go on clopidogrel monotherapy, I'm in certain select patients, I probably would check a PRU. So for example, when I drop aspirin in a patient who's going home because of their, they just had a PCI and I want to drop aspirin because they're on a direct oral anticoagulant, but Dr. Sharma just put in a bifurcation left main stent, I probably will check the PRU before I send them home to make sure they're responding to clopidogrel. So I think that is the patient. And that maybe I'm treating myself because there's no real data that shows that we would improve outcomes. Would you agree to that?
Yeah, I agree with everything that you said. And as far as clopidogrel, it's generic, so it's relatively cheaper, but not quite as cheap as aspirin, which is still cheaper. It's pennies a day. Clopidogrel is, more than that, but still, it's pretty cheap and globally available. But if I were worried about a high-risk patient, I typically would have gone with ticagrelor or monotherapy. I mean, after all, I think Twilight's the best study in terms of high-risk PCI-type patients, ACS or not, where you're going to de-escalate to monotherapy. So I feel very comfortable about that approach and would typically do that. I think what is uncertain is what to do if you're going to continue that long-term. That is, I would do 90 BID for that year. And then at the year, do you de-escalate to 60 BID? That's not really evidence-based, but in fact, often what I would do in that situation.
Okay, Dr. Shan, last question from you.
You didn't comment about Parasugal.
Yeah, so prasugrel monotherapy, is that what you want to know about? Very little
Instead
data.
of checking the,
Yeah, so prasugrel, we do use prasugrel,
once a day.
but it is a once a day. But prasugrel monotherapy has much less data. There's very little data, but there'll be more data coming out. There are several studies that are going to read out in 24 and 25. Should
Okay.
work.
It should work. But with that note, thanks to all our speakers. Great session.